In this video, we will see how to see stroke on MRI. Here is an overview of MRI stroke protocol, which includes these sequences: diffusion or DWI, ADC, FLAIR, SWI, angiogram, and MR perfusion, and we have to go through each of these sequences one by one. First, we see diffusion weighted imaging or DWI, in which we look out for any areas which are bright on DWI as well as show drop on ADC, meaning that same area should be dark on ADC, and this combination is called as restricted diffusion. Now, what is restricted diffusion? Let's look at this example where we have this normal cells and water molecules around the cells, and normally these water molecules are free to move around the cells, meaning there is no restriction of diffusion normally. But what happens when these cells die? The water molecules move inside the cells and the cells swell up, and now the movement of these water molecules becomes restricted by the cell membranes, and this phenomenon is called as restriction of diffusion. In this case, we have restriction of diffusion in this region, which is supplied by the left middle cerebral artery. So this is a left MCA territory infarct. Then we see FLAIR sequence, and we need to see that whether the infarct that we see on DWI and ADC, whether we can see this infarct on FLAIR or not. Here we cannot see this infarct on FLAIR, so this is a FLAIR negative infarct, which means that the onset of this stroke is within 6 hours. That is the importance of FLAIR sequence. Now it's a FLAIR negative infarct. So what? The importance of this is that IV thrombolysis, which is a therapy for stroke and which can be very crucial in some patients, it can only be given if the onset of stroke is within 6 hours. After 6 hours, the infarct that we saw earlier has become FLAIR hyperintense. We can also see this FLAIR hyperintensity in the white matter with some atrophy of the chyri, and this appearance is suggestive of gliosis, which is seen in chronic infarcts. SWI is susceptibility weighted imaging, which means that if there is any thrombus in any of the arteries, it will look black. Also, if there is any hemorrhage or any chronic blood products, they will also show blooming. So hemorrhagic stroke or SAH can also be detected on SWI. Then we perform a brain angiogram. This is the anatomy. We have both the vertebral arteries, which join to form the basilar artery, which gives the PCAs or the posterior cerebral arteries. Then we have the internal carotid artery, which gives the middle cerebral artery and the anterior cerebral artery. You might have noticed there is this abrupt narrowing of the left MCA, so this could be because of a thrombus. On MR perfusion, we see this large area of hypoperfusion, which is suggestive of an ischemic penumbra. Which means that this is the region which is prone to infarction. it has not undergone infarction yet, but it is prone to infarction. This is the region which has already undergone infarction. So this is the region which can still be saved by various techniques such as IV thrombolysis or mechanical or chemical thrombolysis or mechanical thrombectomy. In our case, the patient underwent mechanical thrombectomy. This is the angiogram done after mechanical thrombectomy, and you can see that the left MCA is recanalized here, and all these arteries are fully opacified now, and you can imagine that we have saved so much of the brain tissue from undergoing infarction. If you compare it with earlier, you can see the abrupt cutoff here and the fully recanalized MCA here after the mechanical thrombectomy. This red area is the brain tissue which is supplied by the left MCA, and you can imagine that we have saved this much of the brain tissue by early diagnosis. We had diagnosed the patient within 6 hours, and immediate treatment, we gave the patient IV thrombolysis and the patient underwent mechanical thrombectomy, which is why that only some cortical FLAIR hyperintensity is there and rest of the brain tissue is relatively fine. Otherwise, this also would have undergone gliosis like you see here. Also tells you the importance of MR perfusion images. You should be aware that if there is a small region of infarct on diffusion and a large perfusion defect, which means there is a large diffusion perfusion mismatch, that means there is a large area which is prone to undergo infarct, and which is why you should be aware of this, because this area can still be saved. Here's a summary of the entire thing. So we first saw the diffusion and ADC, then we saw that it was negative on FLAIR, then there was an abrupt cutoff of the left MCA on angiogram, and this huge ischemic penumbra on MR perfusion. Then we did mechanical thrombectomy and the left MCA was recanalized, and we did follow-up MRI which showed this FLAIR hyperintensity along the left MCA territory, and we saved rest of the brain parenchyma.